The Arrow-Karlan Introducer Laparoscopic Cholangiography set with Karlan Balloon Catheter permits entry through a 5 mm trocar port into the common cystic duct to identify ductal anomalies and common duct stones. Warning: practitioners must be aware of complications associated with cholangiography, including contrast reactions, injury to the cystic or common duct, pancreatitis, and cholangitis. The Arrow-Karlan set includes the following components: 5 mm introducer cannula, 4 French 60 cm Karlan balloon catheter, 1 1/4 milliliter control stroke syringe, 3-way stopcock, flush infusion port of balloon catheter and any attached tubing or stopcock with sterile saline. Be certain to remove all air bubbles. Connect syringe to balloon port on catheter. The balloon port can be identified by its pre-attached stopcock valve. Advance catheter so balloon is outside metal introducer cannula guide catheter assembly. Test balloon by inflating with air. To inflate balloon, open balloon stopcock by turning lever parallel to catheter. Inject 0.6 cc of air. Observe balloon for leakage. Deflate balloon and disconnect syringe. Caution: do not test balloon with saline or water. Fill syringe with 1/2 cc of sterile saline or water. Evacuate air from syringe and attach syringe to balloon lumen. Aspirate to evacuate air from extension line and stopcock. Position air pocket behind fluid in syringe. Caution: do not inject, do not disconnect syringe. Precaution: prior to insertion, withdraw balloon catheter into guide catheter assembly and withdraw both catheters into metal introducer cannula to protect balloon catheter from damage during insertion. Make a small incision in the cystic duct as far from the common duct as possible. Pass the metal introducer cannula containing catheters through a previously placed 5 mm abdominal trocar port. Advance the metal introducer cannula until the tip is beyond the end of the trocar and near the cystic duct. To aid balloon catheter insertion, the metal introducer cannula should approach the cystic duct at an angle to lie parallel to it. Precaution: the catheter should be inserted and manipulated under direct visualization. Insert the balloon catheter through the guide catheter into cystic duct. Advance balloon catheter until black band proximal to balloon disappears. To aid with placement, additional black bands are located at 1 cm intervals referenced from the proximal end of the balloon. Caution: do not advance the catheter any further than necessary. Precaution: do not advance the catheter into the common duct. Inject saline through infusion port to verify that tip is not blocked by a valve in the cystic duct. If saline is difficult to inject, reposition catheter. When catheter is positioned in the cystic duct, note fluid level on syringe barrel. Inject 0.1 to 0.2 cc of fluid to inflate balloon approximately 6 mm in diameter. For larger cystic ducts, up to 0.6 cc may be used for balloon inflation. Maximum balloon diameter is 8 to 10 mm. Caution: do not inflate latex balloon beyond stated maximum inflation capacity of 0.6 cc. Exceeding this volume will not appreciably increase the diameter of the balloon and will increase the possibility of balloon rupture, cystic duct damage, or obstruction of catheter tip. Turn stopcock level perpendicular to catheter to maintain balloon inflation. Continue cholangiography using standard operative procedure. After cholangiogram is completed, turn the lever of balloon stopcock parallel to catheter. Aspirate to deflate. Note: if balloon deflation is difficult, use a larger syringe to withdraw. Warning: deflate the balloon completely prior to withdrawing the catheter to minimize the risk of damage to the cystic or common duct. Withdraw catheter from cystic duct and into guide catheter. Withdraw both catheters into metal introducer cannula. Remove entire assembly as a unit. Inspect catheters to make sure entire length is withdrawn. For more information or additional support, contact your local Teleflex sales representative or Teleflex surgical support.